Hello, my name is Hannah and I am presenting my case study on Leptospira interrogans. I chose to do lepto because it is a zoonotic disease, and both my parents are veterinarians who worked in Hawaii for several years, and it came up frequently, and it was always interesting to hear the differences and similarities in pets versus people. So I wanted to dive into it a little bit more. I've not personally had a patient that I've done a lepto workup on, but when looking for a case online, I found a case of a guy in the Navy who got it in Hawaii during a mud run, and I just thought that was super interesting and I wanted to read more about it. I was also in the Navy. I have done mud runs. I have spent a lot of time in Hawaii, so it was just super interesting. And I found some similarities and I just wanted to dive deeper into it. So that is why I chose my case study, and we'll get started. Patient history: we have a 23-year-old, otherwise healthy male prior to this trip to the ER. They are serving on active duty military in the Navy at Pearl Harbor on a submarine. There is no known illnesses or infectious disease outbreaks on the submarine. Unknown family history. It was noted in the case study that they were adopted from Romania as a child, so nothing's really known about their family. What is known, though, is that they had Bell's palsy as a child due to Lyme disease, which I found it really interesting that they had Lyme disease as a child, and now lepto. That's crazy that you would have two vector-borne, like, kind of odd diseases like that. I don't know if it's bad luck or they're somehow connected or one makes you more susceptible, but I thought that was an interesting thing to note. This patient presented to an ER in Maryland following a 5-day ski trip to Vermont with a friend, where they said they were skiing pretty hard for 5 days straight. The patient was complaining of fever, chills, severe malaise, myalgias, severe dyspnea, a lot of difficulty breathing, muscle pains, super tired, overall not feeling great. They were very dehydrated, a temperature of 102.7, super high, a heart rate of 131 beats per minute, also super high, respiratory rate of 48 breaths per minute, super high, blood pressure 94/40, pretty low, and then O2 sat of 55%. That O2 sat was taken when they were already on 100% oxygen via cannula, so that's super low, super concerning. Not great vitals to have in the ED. Something's definitely going on. It did note in the case study that initially when the patient presented to the ED that they were kind of in a rush to leave because they needed to catch a flight back to Hawaii to get back to base for work, but later returned only a few hours later because the difficulty breathing got so severe, and that's when these vital signs were taken, was that second time that they stayed in the ED. The patient rapidly declined in the ED. They went into acute respiratory distress syndrome shortly after being admitted and were emergently endotracheally intubated. Upon intubation, there was a lot of bloody tissue and secretions that came out with that tube. That was quite concerning. They were then airlifted to a critical care resuscitation unit. There, they were empirically treated with vancomycin. Well, excuse me, I will try to pronounce all these antibiotics correctly. Vancomycin, ceftriaxone, azithromycin, doxycycline, and oseltamivir. They also, antibiotics are hard to say, but we got through it. They were also started on venovenous ECMO, which is extracorporeal membrane oxygenation to support lung function. The lungs were failing. They could not breathe on their own. And then it was interesting, I can talk more about it at the end of the case study, but at the time, this was in 2015, they were only the second patient ever to be treated in the US with ECMO due to leptospirosis. So that was started, and that was the ECMO that only supports lung function, so they were not supporting the heart at that point. They were also placed on vasopressors and continuous renal replacement therapy. It was an option alternatively to dialysis since the patient was not awake or able to do dialysis, but they were going into kidney failure. In the first 24 hours of being admitted, they did receive 12 units of plaqued red blood cells just to try to keep their hemoglobin above 7, just because they were losing so much blood due to a pulmonary hemorrhage and no oxygen. very little oxygen. They were placed in contact, droplet, and airborne isolation just because the doctors at this point had no idea. They were suspicious of a few things, but nothing had been diagnosed yet. So to keep everybody safe, they were placed with all those isolation measures. They did a bronchoscopy that showed severe erythema and inflammation of the mucosa in the lungs, which was also concerning. Okay, our lab results, our favorite part. So a lot going on with this patient. We have a serum creatinine of 2.3, so quite high, definitely indicating some sort of kidney failure somewhere. Kidneys are not doing what they're supposed to be doing. Creatinine kinase CK, 2,811, super duper high. Initial suspicion for this patient in the ED was rhabdo with the clinical presentation, and then also following their recent ski trip and kind of symptoms. It kind of lined up with rhabdo. A lot of symptoms, definitely some symptoms couldn't really be explained, but that was an initial differential diagnosis. So super high CK. We have a high PT, 16.9 seconds. PTTs a little high but normal with a normal range 29 seconds. INR a little high, 1.4. Our WBC count really high, 18.3. Definitely some leukocytosis there. Hemoglobin is 7, very low. That is why transfusions were started and maintained, just because they were trying to keep that hemoglobin at least above 7, but with the baseline starting at 7, that is difficult. So they were transfused a lot of units in that first day. And then platelets are low, 96. Also noted in the lab report was an increased ALT, AST, and bilirubin. So something's also going on with liver function, and protein and blood were present in the urine. Not good. So all of these labs do kind of align with that multi-organ failure that is seen with lepto, or multiple organs being affected with lepto. We're seeing that the kidneys are being affected, the liver is being affected, obviously the whole respiratory system, now our coagulation cascades all messed up, and then in our CBC too, we're seeing those white blood cells trying to kind of attack something. So kind of everything is being affected right now. The good news is all of these tests did come back negative, so they could all be ruled out, but also hard as well, because if it's none of these things, then what is it? So that's kind of what the case study made it sound like. They were having a difficult time trying to diagnose what was going on. So they will run through these quick. They were negative for HIV, hepatitis B and C. Viral PCR came back all negative, the nasal swab, and they did a bronchial lavage. I forgot that word for a second. Blood cultures were negative, bronchial lavage cultures negative, blood and bronchial lavage fungal cultures were negative. Nothing seen on malaria smears, negative for Legionella. Strep pneumoniae, CMV was negative. Lyme, IgG, and IgM were both negative. The PCR for Ehrlichia staphylococcus, that one's hard to say. Oops, I got a little cut off on my last slide. I accidentally clicked on something trying to move my video out of the way, but I accidentally paused it instead. But the last tests that were negative that I wanted to note was the Ehrlichia staphylococcus, anaplasma and mycoplasma, and hantavirus. The IgG was positive in all of those, but the IgM and PCR confirmation were negative, so those were then ruled out. So we have all those lab results back. We have clinical presentation. This patient has now been admitted for several days. They're on ECMO. Radiographs don't look great. They don't look great. Definitely having a really bad pulmonary hemorrhage. And so doctors are trying to figure out what in the world is going on. It's something else. They were kind of rhabdo was kind of ruled out at this point, but they were expecting either lepto or dengue fever at this point, which is when the family brought to them a picture of the patient. A few weeks prior in Hawaii, they had competed in a mud run race called the Warrior Dash. They showed the doctors a picture of the patient covered in mud. They said that he ran this. It was 14 obstacles. protocols, and they all included full body exposure to mud and fresh water. At this point, the clinical presentation, symptoms, patient history, exposure, and this one last clue that the family offered were all consistent with leptospirosis, and that is when some very specific leptospirosis labs were tested. So let's take a look at those results. Okay, serologic testing and patient diagnosis. So for leptospirosis, the IgM was positive, meaning current infection. There was a fourfold increase in IgM titers from acute to convalescent phase. Definitely indicative of lepto. They had a positive PCR for Leptospira interrogans, Cerevar ictohemorrhagica, and Mencario. Ictohemorrhagica most often causes the diffuse alveolar hemorrhage that we were seeing with this patient. And it can lead to wheel syndrome and just the whole body being affected. That's why we're seeing the high bilirubin, the kidneys being affected, the liver being affected, the whole respiratory system. And then this also led to leptospirosis pulmonary hemorrhage syndrome. And then on our right here is a picture of what the spirochetes actually look like. They usually have hooked ends on both ends, and they're super tight coils compared to Treponema or Borrelia. Yeah, super tight coils, and we'll go over a little bit more about the organism on the next slide. And these are only seen in dark field microscopy. Okay, some facts about the organism itself, Leptospira interrogans. This does cause a zoonotic disease, leptospirosis. It's primarily transmitted through the urine of infected animals, thinking small mammals, dogs, pets, and it can either be contracted directly that way or through contaminated water and soil. So anywhere an infected animal urinates, it's going to get into, and that can be a source for contracting it. That is why it's such a big deal in Hawaii, because there's just so much mud and water and it's so wet, and they already have a high prevalence of it. So when pets get it and they're peeing in all these places that people recreate, that's where it becomes an issue. It is contracted through It's contracted through mucous membranes and any abrasions on the skin. So yeah, anywhere there's little cuts or scrapes or eyes, mouth, nose, anywhere like that. It is an obligate anaerobe. It's not visible with bright field microscopy or in a gram stain. Actually, it needs silver stain and dark field a dark field microscope to actually see the organism and see the spirochetes. It, as we saw on the last page of the photograph, it is tightly coiled, super thin spirals. They're all very close together, which is what differentiates it from the other two spirochetes that we learned about. The best specimens to test for are whole blood, serum, CSF, and urine. They're preferred and can be used for a number of different tests, ideally the CSF and serum. Serology is the most common laboratory diagnostic method. It was used for this patient. And then PCR does help make a diagnosis early on, and it's much more sensitive than culturing and takes far less time. Once those IgM antibodies start developing after that first week of symptom onset, it can usually be diagnosed by PCR, and then treatment can follow to hopefully get this patient the quickest recovery possible. You can culture it on Fletcher's semi-solid medium, but it must be kept in the dark at room temperature for 6 weeks. So it is pretty hard to isolate. It's not as quick as, say, I don't know, an E. coli on a urine culture that you could get back in 48 hours. So yeah, it does take a while. So it is not the chosen and most common method, but it is possible and it is done. Treatment and follow-up. This patient was on ECMO for a total of 126 hours. That's about 6 days, and at the time I mentioned a little earlier, they were only the second patient to be treated with ECMO following DHA from a leptospirosis infection. It proved successful in this case, and it has since been used about a dozen times since 2015 for other lepto patients, and it has been mostly effective. Especially because of that lung failure that they experience with the pulmonary hemorrhage. They were also treated with ceftriaxone and doxycycline for 10 days. They did make a full recovery after about 2 weeks in the hospital, and they returned to active duty 5 months later. They underwent a lot of medical testing and things to get back into shape for that. They said they felt significantly weaker, but they were in the hospital for 2 days on ECMO, trying to get through a leptospirosis infection and pulmonary hemorrhage. So that would take a bit of recovery time, but they did make a full recovery. The patient was still stationed in Hawaii at the time, and the case study noted that they frequently wanted to warn others about leptospirosis while hiking in Hawaii, and that it's a thing that can happen. Most leptospirosis cases in the US actually occur in Hawaii and Puerto Rico, and they are primarily from recreational activity. So mud runs, triathlon, open water swimming events, hiking, things similar to this is where it commonly happens. Some cases have noted that they want to treat athletes like empirically in case of that, but there's not really any good evidence so far to back that up that needs to happen, but it is in talks. When I was reading on the CDC website, and then in our microbiology textbook, it looks like there's about 100 to 250 cases a year, so not super common. That's still a lot, but comparatively not a ton, but it is one of the more common zoonotic diseases that occurs in the US. Oops. Thank you for listening to my case study, everybody. I really enjoyed putting this together and learning more about lepto. In this case, I found it super fascinating to read through and put all of this together and to present it to everybody. So I hope you enjoyed it. I'm free to answer any questions about anything. I used an article online in a journal called ID Cases, which is where I pulled a majority of this case study from. I thought it was really well-written case study. They included, I think, all the pertinent information we needed. They were good about including all the labs, I feel like. And then also our textbook had a good section on lepto, and they also had a case study in there that was interesting. And then our micro lecture about Spira sheets I used as well. So thanks for following along, and I hope everybody could learn something and be safe out hiking in the mud and fresh water in places that get a lot of lepto infections.